Good morning. Thank you for joining our meeting this morning. I'm Siska, and in this opportunity, I will present it about triple assessment in breast cancer. The commonest mode of presentation of diseases of breast is a lump. A palpable mass in women's breast could be a benign or malignant lesion, and it requires a prompt evaluation. Correct preoperative diagnosis of a breast lesion is essential for optimal treatment planning. The primary aim is to confirm or exclude a cancer. A single modality test is not accurate enough to make the correct diagnosis for a breast lesion. However, the accuracy of the diagnosis can be increased by employing multimodality tests. The triple test, which is initially described in 1975, is the evaluation of palpable breast masses by physical examination, imaging, and histology. And it is said that the triple test is accurate and can replace open surgical biopsy for diagnosis when all three components are concordant. And what is the outline of our discussion this morning? We will discuss about what is the triple assessment in breast cancer, what is the interpretation, and what to do next after doing every sequence, and why is it so important to diagnosing a breast cancer. A breast cancer evaluation should be an ordered inquiry that begins with symptoms and a general clinical history. This is followed by a sequence that has become formalized as a triple assessment, which includes the following components: a clinical examination, imaging, usually using mammography or ultrasound of the breast, and needle biopsy. The sequence has its own advantage that we'll discuss later to point the reason why the triple assessment is important in breast cancer diagnostic. Like I said before, the first sequence of triple assessment in breast cancer is a clinical examination. Breast clinical examination consists of taking patient's history and the breast physical examination. In taking patient's history, a detailed history and thorough clinical examination provide an important information on which to base further investigation and should be accurately documented. In taking patient's history, we need to take a history of the presenting symptom, which contains of the site of the lump, is it constant or changing, the duration of the when or how it first noted, any changes since first noted, relationship to menstrual cycle, is it getting bigger when the patient's in her menstrual cycle, and the associated symptoms to the lump. And we also need to take a relevant history, includes the details of previous breast problem, the risk factor, particularly strong family history of breast or ovarian cancer, the hormonal status, menstrual history, recent pregnancies and breastfeeding, the current medication that the patients take, or recent changes in medication, especially exogenous hormones, and previous radiation therapy or previous breast surgery, including cosmetic surgery of the breast. And in breast physical examination, which consists of two aspects, the inspection and palpation of the breast. In inspection, it is done when the patient is sitting or standing with both arms relaxed beside the patient and with the movement of lifting both arms or hung limply on both sides of body and raised upwards like this as high as possible. What we inspecting in this patient is the skin condition in both breasts. We need to note is it normal, or if there is skin retraction or ulceration or penetration or purity orange or the changes of color of the skin, or if there is skin nodules, and focused on the areola, we need to take note if there is a nipple erosion or nipple discharge. And in palpation, it is done when patient is in supine position. Using the polar part of the second to fifth finger, start the examination from a healthy breast. And when patient in sitting position, look for an enlarged axilla lymph node, clavicular lymph node, infraclavicular lymph node, and to determine the tumor mobility against the chest wall. When lying down, the breasts are flat and dispersed. Examination can be radial or circular. The important thing is that all breast quadrants, including the areola, must be examined, including the axilla and infra and supraclavicular area. And from before, we can conclude that this algorithm, if there is changing or if there's an abnormality from the breast clinical examination, we need to move to the second sequence, which is the imaging evaluation. The breast imaging consists of mammography, the breast ultrasound, and breast MRI. Breast ultrasound has become a widely available and useful adjunct to mammography in the clinical setting. It is generally employed to assist the clinical examination of a suspicious lesion detected on mammography or physical examination. As a screening tool, breast ultrasound is limited by a number of factors. Most notably is failure to detect microcalcification and its poor specificity, which is only 34%. And breast ultrasound is a real-time dynamic imaging examination. It is based on conduction and reflection of high-frequency mechanical sound waves or ultrasound in breast tissue. From breast ultrasound, we can, like what I show in the slide, like the shape, the orientation of the lesion, the margin, border, echo pattern, internal structure, posterior features, edge shadowing, a decalcification. Mammography is a low-dose X-ray based modality used to image the breast. It is currently the best available population-based method for detecting breast cancer at an early stage. The sensitivity of mammography increases with increasing age. Sensitivity is improved with the addition of ultrasound at all ages, although the size of this benefit is greater in women under the age of 50 years. It is defined by American College of Radiology using Birat's lexicon. Each lesion has its own categories, like Birat's category 1. It's describe a normal breast, and in category Birat's 5, it is described as highly suspicious breast lesion. And mammography is taken in two positions, the mediolateral oblique projection and craniocaudal projection. In effort to overcome the limitation of mammography on ultrasound of the breast, MRI has been explored as a modality for detecting breast cancer in women at high risk and in younger women. Breast MRI examination has high sensitivity to detect hypervascular areas in the breast through imaging the inframammary structure in the form of a thin layer before and after contrast administration. MRI, there is mass lesions or densities, calcification, and architectural distortion. And biopsies can use two methods, the core needle biopsy and fine needle aspiration, or FNAB. The fine needle aspiration may be used to confirm the diagnosis of a cystic lesion or fibroadenoma identified by diagnostic imaging in centers with cytopathological expertise. Fluid aspirated from a cyst or for diagnostic purposes should be sent for pathological examination. This is an algorithm for FNIB. If the sample taken in using FNIB is not is hard to identify, then we can move to the next method, which is core needle biopsy. Core needle biopsy is preferable for the investigation of suspicious lesions or when additional information such as tumor type, histological grade, and receptor status of cancer is required. This information is particularly important for patients who may be considered for neoadjuvant chemotherapy. This algorithm, we can see that using core needle biopsy, it is already decided that the tumor was malignant. The patient can continue to the definitive treatment, and if the tumor was hard to identify it using core needle biopsy, a repeat of core biopsy is needed. From what we discussed before, we can conclude the breast diagnostic algorithm. So, like I said before, that the breast cancer evaluation using the sequencing from clinical examination to needle biopsy, this approach naturally lends itself to a gradually increasing degree of invasiveness so that a diagnosis can be obtained with the minimum degree of invasiveness and consequently the minimum amount of discomfort to the patient. Because the more invasive investigation also tend to be most expensive, this approach is usually the most economical. The aim of evaluation of a breast lesion are to judge whether surgery is required and if so, to plan the most appropriate surgery. The ultimate goal of surgery is to achieve the most appropriate degree of breast conservation while minimizing the need for reoperation. And why is it so important to do a triple test? From the research, the accuracy of diagnosis of breast cancer on physical examination is only 70%, around 70% in several researches, even in the most experienced hands. To come to a definite diagnosis, clinical judgment needs to be supported by specialized investigation. The two techniques currently available that have excellent patient tolerability are mammography and FNAB. However, if employed alone, the accuracy of mammography and FNAB is only around 80 to 90%. Triple assessment, the accuracy of diagnosis reaches 100%. The triple test in breast cancer also range from using the most simple modalities, then advance to the invasive modalities to minimize the discomfort of the patients and to make the diagnostic process to be more economically efficient. So that was my presentation about the why triple assessment in breast cancer diagnostic is so important. So this is have its own advantages and disadvantages, but mostly it advantages the patient. Okay, thank you.